And we're open.
EMS.
Eric Shirtliff is in.
Let's see if I think he's in the presenter. He's in the group. Gotta find him. There he is. He should be coming up now.
Looks like he's there.
Yeah, I'm here. I just
Beautiful.
have to figure out to share my screen.
I can stop sharing so you can do that.
Okay. Oh wait, where did it go? Come back.
That was me. Do you want it back?
Yeah, I got it back.
Stand by. Oh, where'd it go? There it is. Share.
Ah,
1 second. Oh, you've got yours up.
what's that?
You're all set.
I'm sharing. Can you guys see?
Yep, I can see your
Okay.
stuff.
All right, rock and roll. Let me see if I can do. What happens if I do this? What do you get? What do you see now, Eric?
I see your presentation screen. I see your presentation screen that you want for yourself. If you flip it, you should be able to.
Yeah. My experience, Eric, is if you move screens, if you move that to your other screen, it will work.
Okay, let me try that.
Like just drag it over.
No, I think it actually kind of matters. I think matters which thing I'm sharing because I'm seeing it in full. Let me just try this again. All right, now what do you see?
That's perfect.
I see your presentation.
Okay, great. Now
I
I
think-
have to just figure out how to advance it. Boom. Love it. Can you
There
see
you go.
cursor on there too?
We're
Looking
good.
great.
Hot dog.
All
It's all
right.
you, sir.
All right. Guess let's get started. Hi everybody. Eric Shirtliff, trauma surgeon with Maine Medical Center Acute Surgery Group. We are meeting to talk about a really extensively injured gentleman that provides ample stuff to talk about all in one case. Just want to say, really appreciate people making the time, and hopefully this is instructional. We'll review some of the protocols will be mixed in, and we'll talk a bit about hemorrhagic shock and the most effective evidence-based approaches to dealing with that. We'll talk about pelvic fractures, and we'll talk about REBOA and ECMO. Can we do this in an hour? I think we can. So anyway, thanks everybody for coming, and let's go for it. The term thoracoabdominopelvic trauma is a little bit tongue-in-cheek, but this patient we're going to talk about was injured in all those places. And so, again, it gives us a chance to talk about all sorts of things. The basic learning objectives are to review this case, talk about shock and implementation of critical life support measures in the field, also to discuss and illustrate the continuity that arises when we have a patient that presents to us that you have already begun to work on, and to show where all the things you all do in the field lead to once the patient gets here. We're going to talk a bit about how imaging findings correlate to physical exam. I think that's a really important way we can give you some eyes on the inside while you're examining these patients in the field. And we'll talk about pre-hospital shock management and TXA as well. This is mostly, I think the protocol stuff is mostly review. It's come up in prior lectures, but maybe not everybody was at those. But the images we'll talk about and this patient we'll talk about at this point has not been presented. So something new and maybe a few things that are familiar. So to begin with the case, this is a 30s to 50s-year-old man who jumped from a third-story window. On scene, he was found supine, stating, "I'm a schizophrenic and I'm having a bad day, and so I decided to jump." Really sad. It also turned out this gentleman had been off his medications because he could not afford them and did not have help in getting them. He was reporting at the time that the team got to him, severe bilateral leg pain really was his main complaint, but he was also having significant difficulty breathing. The good news for this gentleman was that he was injured in very close proximity, not only to to a EMS station, but also the transport time was not very long either. And I think that was important in terms of his survival from the field and then into the ICU and the OR. He had a deformed left upper extremity on exam. He was tachycardic and hypotensive, so already by the vital signs in the run sheet about class 3 shock, and we'll talk about the different classes of hemorrhagic shock. And he was developing respiratory failure as well. He's very tachypnic, really shallow breaths. The team did not waste time. They established wide-bore access and route. They supplemented his oxygenation, but did not. At that point, they felt they could adequately oxygenate him, and he was able to protect his airways. So the most effective thing to do at that point is to move as quickly as possible to the trauma center, which they did. The scene time was 15 minutes, which was just enough time to collar him, scoop him, and get him into the ambulance. So when he presented to Maine Medical Center, this is the trauma surgeon's resuscitation notes. He had developed acute hypoxic respiratory failure during the primary survey, and so we stopped at A and we intubated right away. And then during that time, his heart rate sort of went up and down, probably as a result of some of the medications and just the fact that he was hemorrhaging actively. We'll see that sometimes where when patients are in shock and we intubate, we may actually see them precipitating a PEA arrest. That's why the resuscitation piece of this is so important. If we're not giving volume during the initial resuscitation simultaneously with preparing to intubate somebody, that can lead to cardiovascular collapse. And unfortunately, it's really a tightrope walk. But the difference between thoracotomy in the emergency department, resuscitative thoracotomy, we have to cross-clamp the aorta in somebody who's hemorrhaging to death versus a smooth intubation, ongoing resuscitation, and then movement to the OR or to IR. Or sometimes it's a matter of minutes and judgment based on who's at the bedside. But at any rate, he recovered hemodynamically, but we did move to massive transfusion protocol, which is for every 6 units of plaque red blood cells and 6 units of FFP, we give 1 unit of pooled platelets, which is essentially 6 units. So the basic idea there is to keeping 1 to 1 to 1 and maintaining hemodynamics that way until we can achieve definitive hemorrhage control. At first, it took a minute to figure out where this guy was hemorrhaging from, though. So he got to the trauma bay, we intubated him, we got his hemodynamics better, but we realized something's going on. We did an EFAST, which is where we look at 4 windows in the abdomen, a cardiac window, and then the lung windows. And so we look between the liver and the kidney on the right side to see if there's blood there. We look between the spleen and the kidney on the left side to see if there's blood there. And we look down on the pelvis to see, is the bladder open? Is there blood in the pelvis? And then we will look at the cardiac window, sometimes from the abdomen below the xiphoid. Sometimes you have to do a peristernal view, and then we'll check for lung slide to see if the lung is up and sliding against the chest wall. The interesting thing to note is that the lung slide, the ultrasound of the lungs, is actually more sensitive than a supine chest X-ray. And when we have a severely injured patient with likely spinal trauma, we can't sit them up, and so it's a useful adjunct. But anyway, it was negative. We didn't find any blood in the belly. We didn't find any life-threatening pneumothorax, although he did have pneumothoraces when we finally got him to the CT scanner. They weren't tensioning at that point. But two other adjuncts to the primary survey is a chest X-ray and a pelvis X-ray, and so we found an open book pelvic fracture, and that was where the hemorrhagic source was. And not only was it an open book, but it was also a shear injury on the left, and I've got some imaging to talk about that illustrates this. Once we got a binder on him, he really stabilized. We were doing two things at once. We were putting the binder on, and then we were also readying to deploy a REBOA, a zone 3 REBOA, which I'll also describe that process and why we do that. However, we got everything set for that, but he really, once he had his pelvis closed with the binder, he stabilized. And he stabilized enough to get him to a CT scanner, which is saying something, given how hypotensive he had gotten. So we were able to stop the massive transfusion once the binder was on. We had the REBOA in place, and we were ready to go up with the balloon if we needed to. We talked to interventional radiology saying we need definitive hemorrhage control here. And they were ready to go. They were readying their suite while we were in the scanner. Like I said, we did find some. We did find bilateral pneumothoraces. I'll show you a picture of these, which we ended up placing chest tubes with. But this was actually not the cause of his profound respiratory distress that he developed and pulmonary collapse, which we can talk about after you see the pictures, because I think a picture is worth 1,000 words there for why we ended up needing to go to ECMO with this guy. But at any rate, his injuries were bilateral pneumothoraces, complex pelvic fracture with fragments adjacent to the left SI joint. There's left acetabular fracture, coccygeal fracture. He had a couple of transverse process fractures in the lumbar spine, but thankfully the spinal cord itself was intact, and there was no significant vertebral column injury that needed anything done. He did have large pelvic hematoma. There's hematoma in front of his left kidney, adrenal. It extended all the way from the pelvis up to iliopsoas on the back, and I've got some pictures to show you for this. And then he did have hematoma at the root of the small bowel mesentery that had us really concerned. Should he develop any sort of signs of compromised blood flow to his small bowel, he was watched very closely, because that would mandate a certain exploration. You'll see the pictures of the displaced humerus fracture. It was badly broken. Same thing with the elbow itself, the olecranon, proximal ulnar radius, and then also you had a wrist fracture. The whole left upper extremity was pretty wobbly. So given his stability, we went to interventional radiology, and the interventional radiologist embolized the left internal iliac artery with several different measures to get it to stop. Gel foam is interesting. It gives you hemostasis for several weeks, but ultimately ends up breaking down. But the Amplatz plug and the coils are permanent, and I'll show you a picture of those here in a second. So that definitively stops blood flow into the left internal iliac artery, which is the branch that goes down into the pelvis and then out to the gluteus musculature. He stabilized hemodynamically. However, Hypoxic respiratory got worse and worse and worse and was eventually refractory to all of our advanced mechanical ventilation maneuvers, proning, inhaled nitrous ox, everything that we threw at him, he threw back. And so he ended up needing to be cannulated for VV ECMO. And I'll talk about that later in the presentation. In order to stabilize his pelvis and get the binder off, he went for external fixation of his anterior pelvis, and they did a percutaneous screw fixation of his left SI joint. And then they had to do extensive incision drainage and debridement for the forearm, and that took a while before they could actually fix that. That was several weeks before they actually definitively fixed his left arm. But he did ultimately recover from his injuries, and after 54 days of managing them, he was ready for discharge. He ultimately stayed a bit longer. It was difficult to find the appropriate rehab facility for him, but he was in our inpatient rehab unit until he did discharge. So these were his procedures. In the ED, we replaced Rabo, we replaced bilateral chest tubes. He went to interventional radiology and had the left internal iliac closed down. Then he went for ECMO cannulation pretty quickly thereafter, in less than 24 hours. And then while he was on ECMO, they did the external fixation, percutaneous screw fixation. Ultimately, he got a percutaneous tracheostomy readying him to come off the ECMO circuit. And he spent about 13 days on it. So 2 weeks is a good run. There were, in the initial, we're getting into 7-10 days. There was a lot of concern that we weren't going to be able to get him off, but ultimately he came off. Then his pelvis was definitively fixed. His arm was definitively fixed. And after all of this, we were able to take his tracheostomy out, and he recovered from a pulmonary standpoint to the point where he could breathe through air on his own. Just want to say this is a big save to the team that took care of this guy. And it really came down to supporting him and his respiratory status, getting access to start resuscitating and moving him to the hospital as rapidly as possible. I think another 30 minutes or something in the field with him, he may have died. So just want a big shout out to the team who took care of him. We are grateful. So here's the fracture. You can see this isn't right. This is supposed to be closed like this. So when that opens, all the blood vessels anteriorly, which are mostly venous, tear, and you have big hematoma develop here. Oftentimes there's a bladder injury along with it. This guy didn't have that. But the other problem is you can see that this is the sacroiliac joint back here. That's gapping. And then on this side, it's much more pronounced. Essentially, that's completely floating. So this guy's left pelvis is completely floating. So not only does he have an open book injury, he has a shear injury, which is when you have falls from a significant height, you will see this, and you will see a pelvis do this. So if I had to put this back together, I'm certainly not a forensic pathologist, but I think this is an axial load on this left leg drives it. Basically, he hit with so much force that it just took his whole pelvis and sheared it. So this was after we had the binder on. And the binder is it's like a pelvis tourniquet, if you can think of it that way. You take where everything is spread and bleeding and you close it down. That's what the binder does. And so when it's correctly applied at the level of the greater trochanter, which is way down here, or centered on the greater trochanter, you can see some of the binder stuff here. It closes the SI joints, which is where the arterial bleeding is. You have venous bleeding in the front and arterial bleeding in the back. The internal iliac comes right in here, and so that gets torn when this type of injury occurs. And so we close that down enough to tamp out the bleeding, and that's why he's stabilized in the trauma bay. You can also see this guide wire here in the sheath. This is the reboa. And so that we put into the common femoral artery on the left side and threaded it up straight to the zone 3. And I'll tell you about the different zones where we deploy this, but this putting a reboa in this location can give you time to achieve definitive hemorrhage control. So time to get in a patient that you can't get hemodynamic stability in the trauma bay, this is something that you can actually do to get them to the interventional radiologist. It's also something that gets deployed in obstetric, in overwhelming obstetric hemorrhage as well. So it has a couple of different uses. And I'll talk about Zone 1 deployment, which had the potential to basically supplant doing ED resuscitative thoracotomies, but the issue is the problem is placing one with a chest injury is problematic. So they don't really get deployed in Zone 1 all that often anymore. Also because if you have somebody that loses pulses in the trauma bay, the resuscitative thoracotomy is the quickest way to obtain hemorrhage control. So before the binder, after the binder, and then there's the Zone 3 reboa in place. The tip of it's right about here, just proximal to the bifurcation of the aorta. And then this is the scanner, so we can kind of show you a little bit. So here's the reboa catheter. This is the aorta coming down, and where the balloon's actually a little bit proximal. And this is part of why we get X-rays. We would have advanced this probably into 3-4 centimeters. Depending on how big somebody is, depends on where that goes. So we always get an X-ray before we deploy the balloon. Had we gone up with this balloon, we would have had to move it up about to there. And then with the binder on, this is the reconstruction of the pelvis. You can kind of see how that SI joint is still wide open. The acetabulum was wide open here, but we got the symphysis closed with the binder. And then you can see here, this is his chest. There's the heart. This is the pneumothorax. That's the air between the lung and the chest wall here and here. And then back here is contusion. So this is lung that is bruised. There's microvascular hemorrhage in there. There's probably aspiration as well, because he was stuck on his back and he was having a hard time breathing. And so that lung is not exchanging gas. And this was more likely than these small pneumothoraces. This was more likely the reason why he decompensated so rapidly and so refractory to other conventional management techniques. So this is interventional radiology. These are their guide wires and sheaths up in the pelvis. These are what the coils look like. So it's literally just like a little spring almost of nitinol that has shape memory, and it goes and expands against the vessel wall and it blocks out the artery. So you can see the hardware is in there. It's inside the artery. And then you look and they shoot contrast. This is called a shepherd's hook angiocath, but they're shooting contrast in the aorta. This is the right side. It's normal. So this is the common iliac artery, and then that goes to the external iliac, and then this is the internal iliac on the right side. So then on the left side, you see that come down common iliac to external iliac, and the internal is completely blocked off. There's that shoulder where the plugs are. And you can also see that there isn't any contrast pooling anywhere, so they know that they've got the bleeding shut down. And you can see 3 days later, the lungs are continuing to hemorrhage, and that sets off an inflammatory cascade. And then you have less and less gas exchange occurring. The contusion expand. We always say when we get a bad pulmonary contusion that we really have to wait 48 to 72 hours before we know which way that's going to go with a patient. And oftentimes we'll take somebody that is just on a little oxygen support and put them in the ICU because contusions have a tendency to blossom just about anywhere too. Same thing with like an intracranial hemorrhage when you have bruised brain. Especially with our older folks, they'll be on blood thinners, they'll be on Plavix, they'll be on aspirin, and those parenchymal hemorrhages can blossom significantly in the first 48 to 72 hours. So he was not exchanging gas. This, you can see a chest tube entering the chest over here, and then you got one back behind the lung over on this side. But the pneumothoraces weren't the issue; it was the contusions. And so he was he was cannulated. So this big pipe right here is in the right IJ. That is one of the catheters for the ECMO circuit, and that is delivering oxygenated blood from the machine down into the atrium. And so then it's going to go into the right atrium, right ventricle, and out to the lungs, and then back around in systemic circulation. So this is bringing oxygenated blood back into the body. And then you can even see down here, that is the cannula that they put through the I don't know how well that projects, but there's a cannula here that went through the through the right femoral vein that they threaded up here, and that's taking deoxygenated blood from behind the liver in the inferior vena cava, and it's taking it out to the machine. So this is the outflow to the circuit, and then this is the inflow back in from the circuit. There's another type of catheter called the Avalon, which can do both. There's a side hole that sits here, and then that sits up here, and then there's another hole that sits down here. But that's a more typical way of doing it. But this is also a perfectly usable way to do veno-venous ECMO or VV ECMO. And we'll talk about that a little bit more here once we get to it. All right. So let's just talk quickly about hemorrhage in the field. That if you know, the team that took care of this patient got rapid wide bore IV access. That's critical. If you can't get something in a vein, IO is just as useful. Being able to move rapidly to resuscitation as they get into the trauma bay is the most it's supported best by the evidence in terms of life-saving measures. It actually has an impact on mortality. And I just kind of wanted to highlight that here. We would still say, try to stop after 1 unit, or sorry, 1 liter of fluid. If you have blood, give blood. If you have kind of patient that is in hemorrhagic shock, and then also TXA in the field is part of this resuscitation. And this is some of the algorithm in the protocol for TXA. If it's less than 3 hours from the time of injury, then TXA is indicated. The major contraindications are isolated head injury. But if you have other injuries plus a head injury, then TXA is indicated. Patients that are younger than 16, it's not well studied in that patient population, although there is more and more evidence suggesting that it works there too. Patients greater than 24 weeks pregnant, and then known hypercoagulable states. And if they're outside 3 hours, then it's not helpful and can be potentially harmful. And then GI hemorrhage, it doesn't help. Always contact OLMC for guidance, and then also just so that the loop is closed, and then mark when you are giving it. The initial 250 milliliters, which is 1 gram, the reason we infuse it over 10 minutes is that if you go faster than that, you can induce hypotension. You can imagine if you have a patient that's already in shock that you now make more shocky with too rapid you could precipitate collapse. Just some basic things about TXA. It's a lysine analog, and it acts on plasminogen. So it interrupts fibrin and it prevents fibrinolysis. So that's basically factors 2 and 1 of the clotting cascade. It interferes with their action, and so it stabilizes clot. If you can imagine, blood clot is really just it's a state of either it's forming or it's breaking down always at all times in the body. If we leave our procoagulant factors and our anticoagulant factors to act in their own way, that's what happens with blood clot. However, when you have trauma-induced coagulopathy, which is why we started using this, you end up where the body is taking every clot and breaking it down, that you have pronounced hemorrhage above and beyond what the actual if you consider just the injury by itself. It's really the TXA that acts on how the body reacts to the injury, and that's why it's useful. Know the time of the injury, 1 gram over 10 minutes, flag the IV line so we know, and then they get a 2nd gram once they get here, and that 2nd gram goes over 8 hours. So here are the classifications of shock. It's knowing all of these things is a little bit more than you need. Really, the important thing is to know that when you're seeing moderate or class 3 shock, they've lost about half their blood volume. The average human male walks around with about 6 liters. So, I'm sorry, not half, a quarter, 25%, to 25, 30%. And depending on the size of the patient, at any rate, sorry, I'm not mathing the math. But at any rate, this is really they'll have lost this much blood volume before you see a marked decrease in blood pressure, a marked and persistent decrease in blood pressure. So our patient was maybe 15 minutes from injury when the team got there, and he was already persistently hypotensive. That tells you how fast he was bleeding from his pelvis. If you're going to look at cap refill, it'll be delayed. If they have no chest injury, there will also be tachypnic because they're trying to offload the CO2 as it's building up from the tissue ischemia because they're not perfusing their tissues. And then severe shock, you're going to see a pronounced pulse over 140, and then they'll really be hypotensive. And so the rest of these things, you start seeing more of the mental status changes when they've lost this much blood volume. So that's in a nutshell really all to think about. Like if you're seeing tachycardia plus hypotension, always assume that is class 3 hemorrhagic shock. They need access, they need volume support, and they need TXA. This is sort of just reiterate some of the things I talked about already. The most critical life-saving measure to be taken in hemorrhagic shock is rapid transport to a level 1 trauma center. That also is supported by a plethora of data. That is just kind of where the rubber meets the road. No pun intended. Rapid transports saves lives. Delaying transport to do either IV access or TXA can be life-threatening. Those things need to happen secondarily while you're moving towards the hospital. Early C notification is critical when you have a very sick patient. That allows us to mobilize the blood bank to be ready to activate massive transfusion, which is what we did with this patient. We were able to do with this patient. We also have our instruments ready in case we do need to open a chest or place chest tubes immediately if they tension on the way in. And then we have the Reboa ready to go. We have the Reboa ready to go for this guy, and we can also know if we need to notify the OR to hold a room for us, or also to talk to interventional radiology to have them spin up and ready to go. So the early C notification is also critical because we can be up and running when you get here. So let's talk about pelvic injury a little bit. I think we've talked a little bit already about some of the forces that act. A pure open book where it's just the symphysis that's blown apart is more typical of motorcycle collisions head-on MVCs. As the disrupted pelvic ring widens, it tears the posterior venous plexus and the internal iliac branches. So all these blood vessels back here start tearing because this opens. You have much more space here than the pelvis was meant to have in that situation. This is not as frequent as lateral compression, but it is certainly life-threatening when it happens. Lateral compression is a lot of folks, the most folks. We see a lot, people falling, and I know you guys are dealing with a lot of falls out there right now. But falling on a hip or something is probably the most common mechanism for this that we see here. The force is directed laterally towards the pelvis, and there's internal rotation caused by the impaction here. These can cause ureteral injury, bladder injury, but in general, these are not the life-threatening hemorrhage type of pelvic injuries. And then vertical shear, which our patient had a component of this, these are typical of falls. So I think looking at his mechanism, it fits. These are thankfully rare, but he fell from over 25 feet, and he drove his left side right off its connection here and here. So the SI displacement of voles is the iliac vessels. So the internal iliacs that's sitting there, or I guess in this picture sitting here, get ripped off as that hemipelvis migrates north. And then again, this is life-threatening hemorrhage in almost all cases. The overall mortality for pelvic fractures is not insignificant. It's between 5 and 30% for all comers. But if you break that down into pelvic fractures with hypotension, you see that jump to 42%. So 10 to 42% for pelvic fractures that display any episode of hypotension, let alone refractory hypotension. And then if you have an open pelvic fracture where the fragments are either into the rectum or the skin and soft tissue have been torn off, those have the highest. Those are half of those patients with an injury that severe will die. But our guy, he was somewhere in the 40% window. So again, a big save. Application of pelvic binder or any other pelvic stabilization device is indicated for all pelvic fractures with hemodynamic instability. So if their pressure is marginal, if their heart rate's up, get a binder on them. That will, as you can see with this case, that will shut down the hemorrhage that is so life-threatening, and it also helps to limit how much the body reacts to the injury and falls into trauma-induced coagulopathy. It's mechanical stabilization of the pelvis. It takes a big ring and it makes it smaller back the way it should be. With shear injuries, if you notice that one of the leg, like with our guy, if one of the legs is shorter than the other, inline track should be applied to the shorter extremity first, and then the binder goes on. And so that is the way to deal with that in the field. So look at the legs, make sure that they're the same length, and then the binder gets applied over the lesser trochanter. This is the procedure for applying it. I'm sorry, over the greater trochanter. You identify the landmarks and you focus on the greater trochanters. And I can go back. Let me just go back a few slides just to show you what I'm talking about with the trochanters. Actually, this is perfect. So the greater trochanter is out here. So that's where the device should be centered, because when you apply the force directly across there, it will close down this part. Okay. You can tell we got this leg down to where it needed to be so that when we applied the force, it would close this ring. The ring is what we're focused on. We're trying to take a big ring and put it back to its native dimension. Okay. So you internally rotate and oppose the ankles. You can use tape or roll gauze to do this. is you want to bring the hips around in their normal position. And you slide the device superiorly, you do a log roll and get it underneath any way you can really safely. But obviously, if you're falling more than 12 feet, you have certainly a concern that you could have a spine injury as well. Then you close the device, ensuring adequate tension. And you keep the lower extremities when they rotate into place, then you know you've got enough tension. So you'll see those ankles come around to normal. That'll indicate the pelvis is closed. These are just some examples. This is an appropriate applied binder. You notice his belly button's way up here, but they centered it on his greatest trochanter, so it's down in here. That's where we want to put it. This is in here, and it's good because it shows you again like the level of the device. It's not up here. You can actually make things worse if you apply it over the iliac crest because that can open this part. It's down low where the binder needs to be. And then the goal on X-ray is to go from this picture to this picture. And we get X-rays and make sure we're closed down before we move anywhere in the trauma bay. So REBOA, what is it? It is a resuscitative endovascular balloon occlusion of the aorta procedure. And this is pretty much the state of the art. This is the ER REBOA. It's made by a company called Polytrauma. I am not a paid consultant of them. And this is what it looks like. So there's a couple of there's an arterial line that goes down the middle, and that's important for the function of the thing. It has a balloon which we inflate through here. And once we have it in the right position, and then this sheath comes off as we're sliding it into place. So I talked a little bit about zones before. I'm just going to mention those things again. So zone 1 is essentially the same thing as an ED thoracotomy. It's up here in the chest. If the patient is bleeding to death from an abdominal injury, that is a place where that application is useful. So if they have an aortic injury below, or if they have hemorrhage from a spleen but they've gotten really unstable, that's not a wrong time to use it. If there's chest injuries, though, we can't use it in that application. So if there's any evidence of a chest injury, we're doing a clamshell in the trauma bay. If you can't put one in zone 2, that is where the kidneys are, and then is also where the blood supply to the bowel is. So you can essentially kill the bowel with a REBOA in that position, and then the kidneys, you can hurt the kidneys too. So zone 3 is below that. You can see the renal arteries are here, so it's down below that. So that's where we were putting our catheter. We had gone up in here and we put it right about there. And that is excellent for pelvic hemorrhage. That's the right place to deploy it. So zone 3, we inserted about 28 centimeters, which is what we did in our guy, but he was really tall, so he needed a few extra centimeters to actually get in position, which is why you always want to verify this with ultrasound, or I'm sorry, with an X-ray, which is why it's difficult to apply in the field. So for a zone 1, you go in 46 centimeters. That should get you roughly in the chest, but you still need the X-ray to confirm position. And then a zone 3 goes in 28 centimeters, and you want to be just below the renal artery, right in here. And when you go up with the balloon, the arterial waveform does this thing. It's great. The systolic pressure is down in like the 60s, 70s. You go up the balloon, then all of a sudden you have normal blood pressure. And so what that's doing is it's taking the legs, the pelvis, everything below that part of the aorta, and it's taking it out. It's no longer being perfused. Its blood's no longer returning. And you're decreasing significantly the circulating volume. You're also stopping the blood loss. Newer iterations of this, we will do a partial occlusion, so we'll slow the bleeding, not all the way, because as you can imagine, it gets hard. The longer you completely occlude something,
the longer it's going to take the body to recover below where you stopped it. So there's sort of there's research looking at partial occlusion maybe being a better, and then partial occlusion without getting a perfect blood pressure being maybe a better way to go about this than complete occlusion. But in the end, it stops bleeding in places where you're having uncontrollable hemorrhage until you can get definitive control. But once that balloons up, you got to get the thing fixed. The other application for a zone 1 would be a exsanguinating liver hemorrhage. So then we'll shift a little bit to ECMO. It is extracorporeal membrane oxygenation. And it really got its start in medical critical care and for ARDS predominantly. And we weren't sure if it worked in the trauma population, but then started working with it probably 12, 15 years ago, and started having, showing real survival benefit for patients that were so critically injured that the lungs didn't work. Essentially, it is lung bypass. It takes deoxygenated blood from the systemic circulation and puts it back in to the systemic circulation. And in the trauma population, we use it in severe ARDS, PE, tracheobronchial injury, and if we have to do a pneumonectomy and the patient is refractory to normal ventilator techniques. You have to do it soon. The longer someone's on a ventilator, the less help ECMO is. If they have a poor functional baseline, then it's a really very lengthy process to decide who gets it and who doesn't. But you have a young patient that is critically ill and has rapidly become that way. Those are good candidates, and that's what we're finding in the trauma literature. This is a different type of catheter. This is a cannula. I'm sorry, an Avalon cannula. You see the right atrium over here and the hepatic vein here. There's a side port of the cannula, and that is the one that is returning blood to the systemic circulation. And then this is the catheter down into the inferior vena cava, just below where the hepatic veins enter it from the liver. And so that's receiving deoxygenated blood from the systemic circulation and taking it back out to the circuit. The cool thing about the Avalon, it's just a single catheter, but it's not always so easy to make sure that the side port is where it needs to be in the right atrium, and that the distal end is past the hepatic vein. So getting these things right requires specialized training and the ability to really do a good ultrasound at the bedside and confirm it's in the right spot. When patients need ECMO here, there's a whole separate team that does this which is the cardiothoracic surgery team, and their critical care folks come in and cannulate for us. And then we manage the patient together until they're ready to come off the circuit. So here's just an example. There's a couple of tubes here. One's going in, one's coming out. This is an oxygenator here. And this is where we decide how much oxygen needs to be put into the blood by the sweep gas. And so the sweep, as it comes down, tells us that they are oxygenating more on their own, and it allows us to contemplate coming off the circuit. It's essentially what it is. These are these are just some of the examples of the controls that are used and how to decide how much oxygen goes into the blood that's going back into the patient. And these are examples of venous ECMO. There's also veno-arterial ECMO, which is used if you have central vascular problems like a PE. So VA ECMO is life-saving in those situations. And this is some of the trauma data that is developing. I think there's more and more studies that supporting it. Overwhelmingly helpful if you pick the right patient at the right time. And so Gerard et al. Looked at, again, there's not that many of these people, so this is a kind of an earlier study, in the 20 teens. So they showed us almost 60% adjusted survival rate in a population of 15 to 26 patients that were injured. They were cannulated via ECMO. And they survived a hospital discharge. So that was, essentially the Kaplan-Meier survival was almost 65% of the patients that were on ECMO versus 23% of the same matched patients that did not go on to ECMO. So that's really significant. I mean, that's basically 3 times more people that were able to go on an ECMO circuit survived from their injuries and were able to be discharged from the hospital. And our guy, thankfully fell into that group. Borsage looked retrospectively at a larger patient population and did comparing earlier initiation of ECMO for ARDS and trauma patients, because we didn't initially think that trauma ARDS was the same as all other ARDS and therefore wouldn't respond to the same types of treatment. But lo and behold, mortality was significantly reduced. Again, the numbers are pretty staggering. Like conventional treatment on a ventilator, 65 of those patients died, whereas at ECMO you had 13%. So that's almost 87% survival there. So a really useful treatment modality when we have it, and thankfully we've got it here. And that's the references, which means we made it before 3. Thank you all very, very much for listening. Are there any questions I can answer, things I can explain better?
Dr. Shurtleff, we have one in the Q&A, which is there is some misconception that TXA may not be as effective when there is a tourniquet in place on an extremity. Can you debunk that for them?
Sure.
Let me just make sure. As in, TXA should not be administered for a hemorrhage to an extremity requiring tourniquet application because the tourniquet has been applied.
Yeah. Well, it all goes back, and I probably should flesh out the trauma-induced coagulopathy discussion at some point. But the reason why it's effective is you're not treating that specific. You're not treating the injuries itself. You're treating the body's response to the injury. So if left untreated, the body will flip into a pro-inflammatory and coagulopathic state. What that means is the body cannot form clot normally. And so it doesn't, and that's throughout the body. What that means is also red blood cells will lyse, and there will be hemorrhage in places that there wasn't even hemorrhage before, because the body has flipped over into a coagulopathic state. So what TXA does is it stops that coagulopathy. And it doesn't matter where the injury is. It works just as well for a ruptured spleen as exsanguination from an open fracture with a tourniquet up, as in hemothorax, as any sort of major traumatic injury that is bad enough to precipitate hemorrhagic shock. It's treating the hemorrhagic shock, not the injury specifically. And that's why it can be broadly applied and has been shown to have survival benefit.
Thank you.
Sure.
We did have one question about how many hospitals at Maine Health have ECMO in the ER, which I believe we are the only hospital that has ECMO.
I think we're it. Yeah. Yeah, and that just another kind of application for REBOA is patient transfer. That's sort of been that was a project that we had sort of discussed and worked on a bit a few years ago, until we started seeing the newer data that was saying maybe that doesn't support that maybe that wasn't a supported move. But Forrest Shepard, one of our I guess I don't call him retired, but he moved on to a different center. He had done some work looking at remote Reboa placement as a way of temporizing hemorrhagic shock in order to get them to definitive control down here. And that's something that probably will come up again. But the issue really is do you have somebody that knows how to put one up? And then as far as ECMO goes, you need specialized cardiothoracic ICU, critical care, and cardiothoracic surgeons to do that. I actually don't know if they have ECMO at East Main or Lewiston, CMMC. My guess is they don't, but I'm not 100% sure. I don't know, maybe Julie, do you know?
I bet I know, Eric, but I missed your question.
Oh, are we the only ECMO capable facility in the state?
I think so.
Yeah, that would be my guess. Yeah. Anybody else?
We got another one from Northern Penobscot County Life Flight to Bangor for these patients. If they had this patient in Northern Penobscot County, up on the Canadian border there, they'd want to life flight them down to Bangor to start a patient like this. Or
yeah,
direct.
I mean yeah, that type of patient, this type of patient way up near the border, it depends on stability. If Bangor has a surgeon and Bangor has interventional radiology and you have a pelvic binder, then that patient can be temporized. We needed the ECMO basically. They will call us for transfer. But we didn't move to ECMO probably till post-injury day 2 or 3. So that part is different. I know that I kind of stump a lot on nearest level 1 trauma center. But basically, if you have a stable patient, reasonably stable patient, come to us. If you have a patient that looks like they're going to die in front of you and Bangor is the closest place, then that's where you stop because they have surgeons and they have interventional radiology. That would be the routing answer. But yeah, this is Maine, right? Like this is the stuff that we all have to try to figure out together is how do we treat our critically injured patients over such a massive geographic area. It's easy when they're down here and they're getting injured, but it's not so easy when you guys are pulling them out of the woods up there. So again, like salutations and hats off. But yeah, I think that's your answer is if they're stable enough to keep coming, keep coming. If they're about to die in front of you, then divert to Bangor.
All right, let's see. I think that's everything so far.
Well,
Yeah.
again, thank you all very, very much. I'll see you down in the trauma bay. I'm sure I'm on nights this week, so
Good luck.
yeah, thank you. Godspeed.
All right, folks. Thank you for attending.
Thanks so much.